Good afternoon. So today I am going to talk about X-linked hypophosphatemia, predominantly as an adult disorder. And so you may be wondering why I have pictured here a child having the burden of carrying this large suitcase down this path. And I hope by the end of my talk that I'll have convinced you that this is a disorder, that the comorbidities that I will be talking about today of adult X-linked hypophosphatemia, in fact, start as soon as phosphate wasting begins. These are my disclosures. The other disclosure I want to make is that both Tom Carpenter and I forgot our hair product in the States. So to take it easy on the photography today, if you don't mind. I don't have to spend any time on this because we've heard some amazing overviews today of the disorder, but I just want to remind everybody that, again, of the bone phenotype and that the bone, the teeth, and other bony tissues are comprised of calcium, phosphate, hydroxyapatite, which we'll talk quite a bit about today. This is just an image from the paper that we published about the maternal demands on the skeleton during pregnancy that I won't be talking about today, but if you're interested, and we had some really amazing findings with that study, they're published here. But what I want to show you is that in this image of trabecular bone, you can see here the osteoblasts, or these large cuboidal cells, which show us that they're very biosynthetically active, that they're making, synthesizing, and secreting osteoid, and yet it does not become mineralized in the phosphate wasting environment. So the focus of much of what I'll be talking about today are in the mineralizing enthesophytes. In the States, we use a Z, not an S. So I don't want anybody to judge me for not being able to spell, which is actually a true thing. I can't spell. But this is the American spelling of mineralization. So yeah, we have the mineralizing enthesophytes here, and we have an example here of the triceps surae inserting into the calcaneus on the dorsal surface. And then here, another image of the actual bone spur, which is the enthesophyte that forms both on the dorsal aspect and also in the plantar fascial region. And then the other thing we'll be talking about today is the osteoarthritis and the osteophytes. So osteophytes are those bony formations that we see at the margins of joints, and they have a very strong correlation coefficient with degenerative arthritis, and are thought to be a compensatory mechanism of bony formation, an attempt to stabilize the joint as we lose cartilage volume. So they're very comorbid features. And I think that's what we'll talk about. So this is kind of a busy slide, but I'm just going to make a couple of points here. So this was published in 2020, and this is a very comprehensive radiological survey of a cohort of patients that we brought to the lab, to Quinnipiac, and also some aged sex-matched controls. The thing I want you to recognize here is that the things that are shaded here in pink are disorders of the joint. And what you'll recognize is that we see disorders of the joint at the spine, shoulder, elbow, wrist and hand, the hip joint, knee and lower leg, ankle. Anywhere where you have a joint, we see a predominance of the degeneration of the cartilages and the formation of osteophytes. The other thing that are not highlighted in pink are in fact enthesophytes, and those are those insertions into the tendon and ligament insertion sites into bone. And you can see again the prevalence is both upper body and lower body again, and that they are very prominent across the population that we studied. And we'll look at some of the impact of these findings on the physical manifestations of the disorder. And you'll recognize, again, that the age here, the average age of the cohort here was 54 years old, which is actually quite young relative to the unaffected aging population, where we might expect bone spurs to be forming from overuse injuries or degenerative arthritis as an impact of aging. So this really does happen in decades in advance, and we'll see findings of enthesophytes in individuals as young as 20 years old, as we've seen today. So picture tells a million stories, so, and we've seen a number of these sorts of images, but what you'll notice here is that we have a complete loss of the articular cartilage volume. The other thing we'll see here are significant gluteal calcification here. We also have calcifications here of the hamstring muscle group, and here at the greater trochanter. You can't see the enthesophyte at the lesser trochanter because of the image, but they're also present. The thing I want you to recognize is the bilateral nature of this entire disorder, suggesting that it is intrinsic to this disorder. It always affects both sides of the body. The other thing we'll see here, you see the mineralizing enthesophytes here. You can see that they're actually bridging on the anterior longitudinal ligament in this particular individual, and we'll see how that affects gait today. We also have the mineralization here of the triceps tendon inserting into the olecranon process, loss of joint space, and again, mineralizing enthesophytes at both at the calcaneus and at the dorsal aspect of the foot. So they're quite prevalent and, again, bilateral. You can see the bilateral nature of this in this particular figure. Again, lots of numbers. I don't want you to, I don't expect that you're going to read the numbers, but what I want you to recognize is that on this panel here, we're showing right and left. And it's ubiquitous that if the right is affected, the left is affected numerically in terms of looking at joint angles. And so you can see that at the hip, there are really significant differences in range of motion at the hip. Also significant differences of range of motion. These are all in the sagittal plane, these particular measures. And significant differences in dorsiflexion, which is kind of expected with those big calcaneal spurs. We also see a significant, again, this is just in the sagittal plane, significant restriction in the cervical spine, which we saw is fairly ubiquitous in the patient population, and it progresses with age. So here we have a picture of an individual who came to our motion analysis lab, and you see here her being set up with a number of motion detectors. And you'll notice on this image here, there are a number of cameras that are installed in the motion analysis lab, and they're able to look at, analyze a kinematic range of motion of every single one of the joints or parts of the bodies that are measured with these sensors, so we can effectively recreate the three-dimensional motion of the major joints of the body. And here we're really focusing on the lower body and then somewhat on the trunk. I can't spell, nor can I advance slides. So these are some of the findings that I'm going to touch upon today. You saw this image earlier, and what you see here, again, is a couple of things. Is you'll see that sort of that forward leaning motion in the sagittal plane, and that's often because of those calcifying enthesophytes in the cervical spine, so that the person obtains a sort of a hunched forward stance, which also affects their center of gravity. The other thing you'll often see is this dorsal tucking of the hip, and that's usually in an attempt so that because they're downward facing, in order to ambulate, they almost have to tuck in the pelvis to bring the head up so that they can see while they ambulate. That puts a lot of strain on those large muscles that support both the hip and the knee, that originate in the lumbar spine. So that's what you see here in the trunk angle. So here we have, compared to the control cohort, you can see there's a huge angle difference in the sagittal plane of the trunk, and that's because of this forward motion that they're unable to accommodate. And you can see that relative to the controls, that this is manifested across the entire gait cycle. Here we have down here kind of a depiction of the gait cycle, and looking at both the stance phase and the swing phase on both the right and the left side. And with motion analysis, we're able to show that at the hip, the knee, and the ankle, again, this is in all three dimensions, there are manifestations or abnormalities in the gait cycle. The details of the muscle groups that dictate the motion, each one of these motions and each one of these joints is clearly stated in the paper. It's a lot of data, but you're certainly welcome to look at it. It was just published in 2020. But almost predictably, we see deviations in gait in both the stance and the swing phase, depending upon the muscle groups that are engaged during those parts of the gait cycle. The other thing I want to mention, again, is the waddling gait. And here, when we talk about the trunk angle, so this was the trunk angle in the sagittal plane. This is the trunk angle in the medial sagittal plane. And so what you see here compared to the controls, I think I pointed it to it incorrectly before, compared to the controls, what we see with the trunk angle in the medial lateral plane is that because these individuals, because of the calcifications, it's very difficult for them to clear the foot when they're in the swing phase. And so what they'll do, so they can swing the right foot, is they'll lean to the left side so that the foot can clear. When they go to swing the left foot, they'll lean to the right side so that they can then clear the foot. And so they kind of have this back and forth motion, and this is what has been termed as the waddling gait, and was confirmed in this study that in fact they do have a waddling gait in order to clear the foot during ambulation. So this is a really wonderful review that came out in 2019, and I really enjoyed reading it, and we have some of our wonderful guests here today that are co-authors on this paper. The thing that really stood out to me is that the paper states, to date, there are no disease-specific recommendations that exist for physical therapy in patients with XLH. And that was always an original goal of the study done with the gait and motion analysis, was to better understand the features of this disorder, of the adult disorder, so that we can create interventions of physical therapy. So that's been really difficult in the patient population because, for a number of reasons. Again, there are no disease-specific recommendations. Also, physical therapists are hesitant to work with patients because they have significant osteomalacia and really don't know how to deal with these individuals. And then there are cases in which they do treat the patient and they end up doing more harm than good. That they, one of the goals, the traditional goals of physical therapy is to try to increase range of motion. And we'll talk about that quite a bit, that is not a desired endpoint for physical therapy in this patient population because of undue harm on the individual. So this was just recently published. So if you want to know more of the details, you can see them. But the goal of this was really to try to address this gap in patient management. And again, treating XLH in adulthood with burosumab or with other therapies is a good thing, but we can't fix everything as it relates to activities of daily living and quality of life with a therapy, that there need to be other interventions supported by other healthcare professions, including occupational therapy for adaptive equipment and also physical therapy. So in this particular study, which happened, we got funded, these are two individuals who did the original study, a 65-year-old female, a 55-year-old male. They had very similar physical findings, not surprisingly. One was 10 years advanced, And in fact, the physical assessment of that patient showed, in fact, they did have advanced restrictions in range of motion relative to the other individuals. So we got everything ready and set up, and then COVID hit and everything shut down. So my students were very motivated to continue the study, and I'm thankful to them that they did, because we did do it. So we went online and bought all the equipment that we needed. We had it shipped to their homes. We bought cameras for their computers. We had those shipped to their homes so we could do everything by video. And it was a little bit of serendipity, because in the end we found that we could implement a successful PT program with a qualified physical therapist remotely. And that becomes really important when you're talking about rare disorders and sometimes limited access to healthcare practitioners. So we started with, again, these are patients we already knew, but we redid the physical evaluation so that we could better understand the restrictions of each one of the joint angles. We did extensive survey and interviews with the individuals, and we also looked at functional range of motion, and that is by having the individual perform different movements or exercises. And it's not that we were taking goniometric range of motions, we were looking at functional range of motion. Do they have restriction or visible restriction in certain motions that we would predict would be otherwise normal? And then we implemented a program where we had 2 60-minute sessions per week. We took extensive SOAP notes. They had a home exercise program that they were expected to engage in 1 time a week, so that we had a 3-time-a-week exercise program. Again, we had weekly feedback survey to try to parse out any shortcomings of the program, to parse out any difficulty that they had, and to also kind of in real time improve the intervention. This continued through weeks 5 and 8. And then in the last 3 weeks, we had them do the home exercise program on their own, and which they had great adherence to. And then we had a number of assessments during each one of these periods. So some of the themes that we captured in creating the program was a significant fear of falling. And we know from the literature now that fear of falling is actually a fall risk. So that anything that we could do to build the confidence in individuals that fear of falling would be an improvement in their quality of life and ability to go out and socialize more. They had very diminished walking speed. We certainly saw that in the gait analysis. The walking velocity and the gait patterns were very much slower. And really a lot of hesitancy for going out and walking on surfaces that were uneven because of fear of falling. Low confidence, I've already mentioned. And the other thing is really difficulty performing our activities of daily living. And these are things that we do every day. Getting in bed, getting out of bed, getting in and out of a car, personal hygiene. So these individuals aren't asking that they want to now climb Mount Everest. They're just asking that they want to conduct the normal things that they like to do in life. They want to go back to baking cookies. They want to walk their dog. So really, what we're talking about here is everyday common activities that we were hoping to affect. So I'm not going to go through these, but as a consequence of the physical findings, of the physical intake, and the findings that we had in that 2020 paper, we were able to put together what are those exercises we need to implement in order to improve the physical findings that we had. So we had a number of measurable outcomes, both subjective, you've seen a couple of these today, subjective and objective, to look at whether we had improvements. We took range of motion measurements, which was a challenge remotely, so that was just generally looking at functional range of motion. Again, I will make mention of the role of changing or looking at evaluating range of motion in this study. So here are the exercises that are uploaded onto Figshare, which are included in the paper, in which there's a hyperlink for each one of these. And the way this particular data has been shown is that here's the exercise is balance progression. Again, we're targeting balance here, which is a very significant issue with these individuals. They each one of the exercises is individualized here, listed, a description of the exercise, a video of the exercise, with instruction. This is one of my students who, they were both doctoral students, both of these guys, they're both doctoral PT students who have since graduated. And so they performed and described each one of the exercises. And then we also had modifications. And the modifications are there so that as the individual became better at performing the exercise, they could challenge themselves, and we would challenge them in real time with modifications that improves the complexity of the exercise or increases the weight. So they may start with 1 pound weight and move up to 3 pound weights, which they all did successfully, which they both did successfully. And again, we make mention on the videos that this is intended to be implemented by a trained, licensed physical therapist, that this is not meant for patients to go on and to do the exercises, that it should be done under the guidance of a physical therapist. So we had weekly program evaluation and feedback. We had absolutely excellent compliance, and they were really good at doing the home exercise program. And I check in with them every now and then, and they still are being very, very compliant, which I was so pleased to hear. All of the subjective and objective measurements we made were all improved. And then we had gains in weekly progress reports. So we had gains in confidence, balance, strength, because we did a lot of exercises that improved muscle strength, and risk-taking with ADLs. One of them was out there stacking wood in his backyard and took photos, and I didn't tell him to stack wood, I promise you, but he felt compelled to now decide to start stacking wood. So the one thing I do want to mention here, this is very different. Many physical therapy programs, if any of you have ever done physical therapy, the goal is to usually to improve, to get yourself back to where you were, and to improve range of motion and any sort of injuries that are restrictive. That is never a goal of X-linked hypophosphatemia. Those mineralizing enthesophytes are mineralized. They're not going to demineralize, they're not going to get better, that you are permanently restricted. You're not suddenly not going to get increased range of motion in the cervical spine, thoracic, or the lumbar spine. And in fact, if you try to improve range of motion, especially in the spine, you have the risk of causing damage to the individual. And there have been a couple of instances of paralysis in patients who have gone to somebody who really isn't familiar with disorder and have had had spinal injury. So we really need to be mindful of that. So the title of my talk was From Bench to Bedside. So we're going to go back to the bench now, where kind of this all began. And I want to, we're going to go through some of the studies that in using this wonderful mirroring model, we were able to gain a lot of insight into the etiology of these comorbidities, but also really illustrate that these really do start early in life. The other reason for doing these basic research studies and doing basic research in general is that we can't treat what we don't understand. If we don't understand the etiology of these musculoskeletal disorders, how are we able to intervene? And so this was a really important question, or these are really important questions. So we're going to take a little shift now to some biomechanical stuff that is important because cartilages and entheses are both biomechanical structures. And so just a little bit of a review here of this is a typical fibrocartilaginous entheses. Here's the tendon, here's unmineralized fibrocartilage, mineralized fibrocartilage in subchondral bone. And so this enthesis is a site of stress concentration. So it's thought that this mineralized zone of fibrocartilage helps to minimize stress. To minimize stress means you're going to minimize the amount of tension that can be put on the tendon inserting into the bone. Here's an image here of this cross section in the mirroring model of the, I think this is the calcaneus of the insertion, showing a mineralized cartilage, and then the subchondral bone plate. And so, again, that zonal arrangements helps to decrease the stress concentration across the surface and really does act as that intermediate type of tissue. The other thing I want to mention is that these develop postnatally. They develop postnatally because we don't have fibrocartilaginous entheses until postnatal period. There are no fibrocartilaginous insertions prenatally. Once, and this has been shown in both mice and in humans, so once a baby's born, those entheses now come from, now develop, now we see the development of fibrochondrocytes, and then they undergo the normal transition to mineralized versus unmineralized. And that is a function of now becoming loaded postnatally. So load is really important in the development of these structures. So just a couple of dictionary of terms so you all kind of stick with me on the next part here. I'm going to use a couple of terms, stiffness. So here, that's most easily illustrated here. If we have a stiff material, everything in the world every material in the world has a defined stiffness. And so if we think about stiffness, we can subject a material to a stress, which is a force. And if we think about putting a force on this really hard brick wall, we can imagine there's not going to be a lot of strain, that there's not going to be any change in how much we can indent that brick. However, if we impose a force on something that's not as stiff, that's more compliant, then we're going to get a bigger strain. We'll see that there's a movement in the deformation or a change in the length of the deformation. So this would be a very stiff material, and this will be a very not as stiff material or a more compliant material. And this would be in compression. Those same characteristics also exist in tension. So here we have something like a really heavy water hose. If we subject it to a tensile stress, it's not going to stretch very much. You're not going to have a lot of strain or deformation. However, a rubber band, which is very compliant, when we subject it to a stress, or a force, we're going to have a lot of strain, or delta L will increase. Okay, so that's just sort of what I want to think about. In the context of the tissues that we're talking about, when we talk about stiffness, it is an intrinsic characteristic of both the cartilages and the insertion sites to be pretty stiff materials. Not as stiff as bone, but stiffer than unmineralized cartilage or unmineralized fibrocartilage. So they're pretty stiff materials. So here, I think I just have a single slide on the entheses in the spirit of time, but we've already heard that this paper was published in 2009 characterizing the hyperplasia of the mineralizing fibrochondrocytes in the entheses. And here you can see this is a calcaneal insertion. We can see with time, this is a 12-week-old animal, a 7-month-old animal. We see it as early as 12 weeks histologically, that we have an expansion of mineralizing fibrochondrocytes. You can see that down here below with the von Casa stain. We also seen evidence of the osteomalacia in that subchondral plate. So in that original paper in 2009, I wrote this in the discussion. It is possible that the transition of a normally smooth tide mark to a highly irregular hyperplastic one seen in both x-rays obtained from patients and with XLH and height mice may be an adaptation to excessive forces. So he always assumed that this was something where we have too much irregular mechanical forces on an enthesis. And so the hypothesis would be that if these hyperplastic fibrochondrocytes are doing their job, the mechanical properties of these tissues should be the same. So an analogy here that I use frequently is if we have a tent with 4 pegs, and it's nice and stable, and then we get a monsoon and the ground becomes very, very soggy, what are we going to do to stabilize the tent? We're going to put more pegs in. So that's effectively what these mineralizing fibrochondrocytes, these stiff mineralizing fibrochondrocytes are doing. So I didn't have the ability to make that measurement because I didn't have the ability to make the measurement until a colleague of mine, Dr. Stephen Tomasini, came to Yale, who's a biomechanical engineer, and I don't think he unpacked his first box before I knocked on his door and said, we have some measurements we have to make. And so we did that. We did a number of stress-strain experiments where we were pulling the tendon. And what we'll see here, without going into too much detail, is that despite the fact that we have this insertion site inserting into a soft matrix, remember, it's inserting into soft bone, what we found was that the biomechanical properties of the wild type and the height mice were identical, which supports the notion that it in fact is an adaptive mechanism to securing the tendon into the insertion site. And the measurements we make here, and you can just simply look at the numbers, that there are no difference in stiffness, ultimate strength, meaning at what point does that tendon fail? So the tendon did not fail prematurely in the height mice. And what was the maximum strain that we could subject, that we could see in both tissues? And they, again, were identical. So it appears it does occur as an adaptation. And in studies that I don't have here today, we unloaded the gastroc muscle here with Botox. With the unloading, and this has been demonstrated in the literature, you don't have fibrochondrocytes that develop. So there's a much smaller number of fibrochondrocytes. When we get rid of those fibrochondrocytes by unloading, we now see a deficiency. They no longer function in the stress-strain curve, which was proof of principle for us that the mineralizing fibrochondrocytes is an adaptive response to osteomalacia. So similarly, we also wanted to better understand the degenerative arthritis. And so to kind of give some foundation of the articular cartilage, it's not, in some ways, there's very much similarities between the tendon insertion sites, the fibrocartilaginous insertion sites, and articular cartilage, and the fact that there are 3 zones: unmineralized articular cartilage, mineralized articular cartilage, and subchondral bone. Again, of increasing stiffness. So that mineralized zone is of intermediate stiffness between the unmineralized cartilage and the subchondral plate. So again, very similar in that sense. We also have the chondrocytes that live in fibrocartilage, like fibrochondrocytes, are terminally differentiated, meaning once we lose them, they don't come back. So which is why degenerative arthritis is such a problem in both the unaffected population and the affected population. Once we lose the cartilage, it's not repaired. Doesn't reform. The other thing that lives in our cartilage are proteoglycans. And these are these large sulfated molecules that they're negatively charged, and they do a great job of holding on to water. And that's what makes our cartilages so stiff. A combination of proteoglycans, water embedded into a collagen matrix gives a tissue that's actually quite stiff and really can adapt to those compressive forces. So developmentally or as a consequence of becoming weight-bearing, we develop joints at the ends of long bones to accommodate compressive forces. So this is just a sort of quick physiology lesson of the articular cartilages so that we better understand some of the studies ahead of time. So what I found, this was published that you can look this data up. So in the older height mice, two things I want to point out. There is no mineralized zone in the height mice. It's gone. We don't know a lot about what the mineralized zone does, so it's not like I could look it up, except for the fact that there were 2 papers published that it has an intermediate stiffness between unmineralized cartilage and subchondral bone. The other thing is that we lost at 7 months 50% of our volume of articular cartilage, so that this, by definition, is a degenerative osteoarthritis. So here we see that in the younger mice, the important finding that we have, if we treat the height mice with calcitriol and phosphate, we were able to pretty nicely restore that mineralized zone of articular cartilage. So the articular cartilage, unlike the enthesophytes, are very sensitive to phosphate replacement and is able to restore the normal hierarchical structure. The other thing we saw was that we saw a huge induction of proteoglycans. So you'll see in the cartilages, we've lost our tide mark, which is that zone between unmineralized cartilage and mineralized cartilage. So that's missing because there is no mineralized cartilage. It's one kind of hunk of unmineralized cartilage with a whole bunch of proteoglycans. And then when we treat the mice, we see a restoration of the structure. We see a downregulation of the proteoglycan biosynthesis. So it really was very responsive. And so one of the questions that I thought was like, well, maybe the proteoglycans are also compensatory. Proteoglycans are synthesized to help resist compressive forces. So is that upregulation of proteoglycans another adaptation? And is it enough to sustain the health of cartilage? So spoiler alert, no, it isn't, because we know they lose cartilages, but it certainly could be an adaptive role. And then, so to better understand this, we also need to do some biomechanical studies. So we asked, what is the biomechanical impact of that loss? What does it do? What does it do to the stiffness of these tissues? And can proteoglycan biosynthesis preserve that mechanical function? So another little mini physiology lesson, and that is the cartilage is a viscoelastic tissue. So a viscoelastic tissue means that when you push on it, viscoelastic tissue by definition means it's both water and solid. Viscous because it has water, solid because we have proteoglycans and other matrix proteins. So one of the things that's really special about articular cartilage is it can resist stress forces. So when you have those compressive forces, it can help resist them because of the intrinsic stiffness of the tissue. The other thing it can do is once you compress it and you impose that stress on the tissue, it's the only tissue in the body that undergoes stress dissipation. That means the stress that's imposed on the cartilage with compression, we see this schematically here, undergoes an equilibrium and dissipates that entire stress. If the cartilages can't do that, we would lose our cartilages really early in life. So that stress dissipation is a very important biophysical characteristic of articular cartilage. So this is the method of microindentation. So instead of pulling a tendon now, we're compressing the cartilages. And this was done with a microindenter, so that we microindented the surface of the entire tibial plateau and took measurements. And this is what you'll see. So it indented at this certain velocity and at that amplitude of 30 microns. 30 microns in the mouse is equivalent to 20 to 30% strain, which is actually a pretty significant strain on cartilages. And then what we see is it develops a peak stiffness. I told you cartilages stiffen on, 5 minutes? Oh, okay. Cartilage stiffen, and so I'm almost done. Stiffen, and so that's the peak stiffness we'll see here. they undergo relaxation. I'm not going to be covering the relaxation component of this today, but any biomechanical nerds in the crowd that want to talk about that data, I'd be happy to discuss it today. So here's an example of the map. These are all the indentation points of the tibial plateau. These are the stiffness values that we get. And we see here that we can have a kind of a heat map of the articular surface, which is never uniform. This is what a typical tibial surface might look like. And then we have a heat map of the stiffness that ranges from low stiffness to high stiffness. And what we see very kind of strikingly here is that the height mouse cartilage is not stiff. It loses its physiological capacity to be the stiff tissue to resist compressive forces. And so here we have the numbers here of the mean stiffness, and you can see when we treat the height mice, so here's just a summary of those data. When we treat the height mice, we see pretty dramatically that we're able to restore the natural stiffness of articular cartilage. And you can see we even reach numbers up in the upper limit that are more physiological relative to the wild-type mice. The last point I want to make is we also did micro-CT, and we know from other publications and in our own hands that the osteomalacia in height mice is not very sensitive to calcitriol and phosphate. And in fact, we saw very poor responses to treatment in many of the parameters. But particularly, trabecular number and spacing are thought to contribute more significantly to biomechanical strength than do trabecular thickness and density. So they don't improve, if you look at the chart, we see improvements in neither trabecular number or spacing. So the effect that we're seeing, we can then ascertain, is that the impact that we're seeing with therapy can't be explained by an improvement of the subchondral bone plate, but can simply be attributed to the restoration of that narrow zone of mineralized cartilage. So what have we learned on this journal? So there is an experimental improvement of articular cartilage that can be largely attributed to mineralization zone of cartilage and not to subchondral bone. Preserving the lifelong environment of articular chondrocytes and fibrochondrocytes with effective therapies are critical to slowing this progression of OA. Integrating load-bearing exercises into activities in daily living are also important to maintaining cartilage health since they are load-dependent cells. And again, implementing adult programs with XLH to preserve ADLs and are augmented with things like fall prevention strategies. I also want to mention that these findings in the cartilage challenge the paradigm that it's a misalignment alone that causes degenerative arthritis in these patients, that it could also be a component of the loss of the mineralized zone of the normal structure of cartilages. This is just the literature cited here. The highlighted names are those students who I've had the honor of mentoring, and I do that because I am hopeful that we can increase the number of individuals who study X-linked hypophosphatemia and really create that pipeline of researchers. I want to thank everybody, and I don't know if I have time for questions.